So now we're going to talk about illness scripts. And as you remember from our schema, we represented the diseases as discrete circles connected to other diseases and syndromes by the neural connections that lead to that particular disease. And those are our schematic representation of an illness script. So let's turn our attention to illness scripts. Illness scripts turn out to be an extremely useful tool for compare and contrast learning. And they are, in fact, believed to be the way in which experts store information about specific diseases. You can think of them as a packet. We've represented them on our graphic of the expert's brain as a circle, and we'll use that circle repeatedly for the next 6 weeks. Turns out, when an expert knows a disease, they store it in their brain in an illness script, and there can be millions of them in any given individual's brains, only dependent on how smart they are and how much they've read and learned about diseases in medicine. They're shaped by reading initially and then refined by clinical experience. So every time you access an illness script, because you have a patient with that disease, you store a little bit more information in that illness script or that package of memory information. And the structure of the illness script and the foundational elements on which they're built facilitate the type of compare and contrast thinking that we were illustrating in our overlapping Venn diagram in the last component of this talk. It also turns out that the way they're developed helps clinicians access information in the clinical environment. So they're arranged in such a way that when a patient presents with a sign or symptom, it triggers or activates that particular memory store in a much easier and more expeditious way than just simply filing them in a random file folder. Now, illness scripts vary between professionals. So my illness script for congestive heart failure and Dr. Papadakis' illness script for congestive heart failure might be slightly different based on what we've read and the patients we've seen. But they're all founded on a core set of 4 elements. And this is work that's been beautifully articulated in Judy Bowen's article in the New England Journal in 2006 on clinical problem solving. And these are the 4 standard components of illness scripts in each expert's brain about every disease that they truly know. A statement of epidemiology, a statement of time course of how the disease presents, a statement of clinical presentation or classic signs and symptoms, and an understanding of the underlying mechanism of disease that led to the clinical presentation and the time course in question. Let's take each of these foundational elements for the illness script in turn and examine them a little bit more closely. So epidemiology in an illness script refers to the question or answers the question, who gets this disease? Who's susceptible to it? In which population of patients might I have to consider the possibility that this disease could be present? So this includes common information about demographics, for instance, age. There are some diseases only the elderly get, and some only the neonate gets. Gender, there are some diseases that only women get, and some that only men get. Race or ethnicity turns out to be a more problematic issue because it's sometimes very difficult to precisely identify what diseases are linked to a particular race or ethnicity. But they have been traditionally used to describe diseases in the medical literature, so I've included it here. Epidemiology also, however, refers to risk factors and exposures. So epidemiology might mean a chronic medical condition that predisposes someone to another condition. So for instance, if I have diabetes, that might predispose me to coronary artery disease. And that is a component of someone's risk for a disease that's being considered or described in this illness script. And similarly, exposures or things that might have increased the likelihood of me developing the disease described by this illness script is included in epidemiology. So that may mean travel. If I traveled to an area, for instance, where malaria was endemic. My occupation, if I've been exposed to asbestos, or if I'm exposed to a lot of children with particular infectious diseases. Sexual activities or hobbies. I'm a bird keeper. I might be predisposed to a particular type of pneumonia. Any types of close contacts who have disease might also fit into epidemiology. But remember, this illness script we're talking about here is about the disease. And so this is all about the types of factors that might be present as I'm considering the possibility of this disease for my patient. So let's give an example of the illness script for acute retroviral syndrome. And this is focused purely on the quadrant of epidemiology. Now, what will be important in considering the possible disease of acute retroviral syndrome is recent exposure to blood or body fluids. That's the epidemiology of relevance here. What's not important is epidemiologic information about age, race, gender, ethnicity, or sexual preference. That doesn't add anything to our understanding of this particular disease. All we need to know is that the person had exposure to transmissible opportunities for HIV. And this points out one element of illness scripts that I want you to begin with as you're starting to build these illness scripts from the foundation up. And that is start with the most important information. Don't try and push everything into these quadrants, because we want you to build a very strong foundation that is applicable to as many people who might present with this disease as possible. The next element we're going to consider is the time course of the disease. It's another core component of the illness script, or the disease illness script. Time course refers to two types of ways in which the disease presents with relation to time. The first is the duration of the prodrome or the symptom. And this generally is expressed in abstract words like hyperacute, meaning it just happened instantaneously. I was fine this morning and by lunch I was horribly ill. Acute, this has been going on for a couple of days. Subacute generally refers to a couple of weeks, and chronic, a couple of months or more. Now, the purist in you might want a precise number of days, hours, or weeks in which something converts from hyperacute to acute to subacute and chronic. All I can tell you is that's not possible, and it varies from disease to disease. What's more important is sort of understanding whether the disease that you're considering generally occurs dramatically, somewhat acutely, or has symptoms that persist for a long period of time. And it turns out time course will be a very important distinguishing feature for much of the work that we do. The other element, though, of time is a description of how, once the symptoms are present, they behave in terms of constancy. And typically you see words like the symptom is constant, stable, or progressive. That's another element of time course. Or you might see that the symptom is more variable. It comes and goes. And we use phrases like waxing and waning, or biphasic, meaning it happened 2 weeks ago, there was a period of normality, and then it happened again. Or intermittent. Miss Jones-Hopper, we heard, has had stomach pain that occurs periodically over the past several months. That would be intermittent pain of a chronic nature. Let's give some examples of time course. So for instance, in a patient who's presenting with a syndrome of meningitis, and by syndrome, remember I mean the classic signs and symptoms. So they have headache, fever, stiff neck, perhaps confusion. If that patient's symptoms have been present for weeks to months, then it's much more likely to be something like tuberculous meningitis, which has got an illness script that has a subacute to chronic presentation, in contrast to pneumococcal meningitis, which happens much more acutely, sometimes even hyperacutely. And in fact, if it's been going on for 2 months, cannot be pneumococcal meningitis. Even more interesting is HSV meningitis, where we see a recurrent acute presentation. So the patient's symptoms come on dramatically. They're sick for a couple of days, then they're fine for months, and they might come back again. So it turns out time course and the way in which disease presents with respect to time can really help us narrow our differential diagnosis fairly quickly, as long as you understand what the illness script is for each of these diseases. The third category is perhaps the most interesting and the most complex, and that is the classic signs and symptoms associated with this disease. Now, remember we talked in our schematic of the expert's brain and the interlocking Venn diagram symbol that we used in the last part about key and differentiating features. Key and differentiating features are features of a particular illness that allow you to distinguish between diseases that may present with the same syndrome. Subsets of these key and differentiating features are what I have called must-have features. That means that this patient, in order to diagnose this disease, must have this particular sign or symptom. Or rejecting features. That is, if a patient has this particular sign or symptom, the diagnosis of this disease that we're considering can't be made. We'll give an example on the next slide. So in a patient with shortness of breath, if the disease illness script you're considering is heart failure, some key or differentiating features might be things like an S3, and let's compare that to pneumonia and pulmonary embolus. An S3 will be present in congestive heart failure, but not in pulmonary embolus or pneumonia. So that would be considered to be a key feature. In contrast, if we're considering in a patient with shortness of breath the diseases of heart failure, pneumonia, and pulmonary embolus, and we're accessing all of those illness script, we'd recognize that RALS might be present in both heart failure and classically in pneumonia. So that's a differentiating feature. And in each of these situations, each of these diseases will have key features and differentiating features that allow you in a given patient to increase or decrease the likelihood of pneumonia over pulmonary embolus over congestive heart failure. Let's talk about rejecting and must-have features. Those are not very common, I have to say. It would be nice if they occurred more frequently. But every now and then, there are really important features that you should understand as a key element of the disease you're learning about. And here's an example of a rejecting feature. If you're considering the possible disease of Guillain-Barré, if we're looking at this as an illness script for a patient with Guillain-Barré syndrome, which is paralysis due to a peripheral neuropathy, the patient has no reflexes in classic Guillain-Barré syndrome. So if the patient whose leg weakness you're evaluating has hyperactive reflexes, you know that we cannot be considering Guillain-Barré syndrome as a possible cause. That's a very useful finding, and it's a critically important fact for you to remember about Guillain-Barré syndrome as you're learning that disease and preparing the Guillain-Barré illness script. Another example of a must-have feature is if you have a patient like Mrs. Hopper-Jones who has terrible abdominal pain and you're considering the possibility of cholangitis, you must see jaundice in order to consider ascending cholangitis as the cause for her abdominal pain. If she doesn't have that, you no longer need to worry about the disease of ascending cholangitis, and you need to seek another illness script that might explain her symptoms and signs. The last foundational category of information found in illness scripts is some description of the pathophysiology or mechanism of the disease in which you're considering. And these are known derangements in anatomy or physiology or immunology, biochemical pathways, genomics or proteomics or metabolomics that are causing this phenotypic constellation of signs and symptoms. Environmental contributors also may be present. For instance, microbiologic etiology of pneumonia or myocarditis, toxin exposure that leads to liver dysfunction, or drug overdose or drug use and an associated side effect might all be mechanisms that you incorporate into your description of a given disease's illness script. Now, as we've talked about the illness script concept, we've talked about it as a packet of information that experts store in their brain when they know about a disease. And as we've talked about it in the last several slides, we're trying to stimulate you to think about building these illness scripts. And in each case, we've articulated a belief that these diseases will present as classic signs and symptom complexes. Those of you who are in the audience who are more expert in your clinical career will recognize that there are variants to every disease presentation. And we will acknowledge that. but we still want to reinforce the classic signs and symptoms concept that we're teaching in this course because we feel it's important that you master the rules before you master the exceptions to the rules. Think about the illness script as a frame of a house. You first build a solid foundation and frame, and then with experience, add details to that house, like drywall, electricity, or plumbing. And just like that, novices will begin to build illness scripts that are founded on that foundation of epidemiology, time course, classic signs and symptoms, and mechanisms of disease. And with time and experience, they will add nuances and elements to the illness script that create a much more robust and interesting illness script over the course of their career. But that foundation will still be strong and help them as they evaluate patients over the time that they spend in clinical environment. So for this module, we have 2 quizzes. The first quiz is illness scripts. Illness scripts are identical between clinicians, classic disease representations, random collection of facts about diseases, or static descriptions of diseases once they are formed. And the answer here is illness scripts are classic disease representations. The foundation is identical between clinicians, but the details may vary from person to person. They're not random collection of facts about disease. They're structured in the elements that we've talked about. And they're not static descriptions once they're formed. They evolve over the course of a career based on further reading and experience with patients. Quiz number 4. In illness scripts, epidemiology refers to, number 1, the biomedical mechanisms of disease. Number 2, a description of classic signs and symptoms of the disease. Number 3, a description of how that disease presents over time. Or number 4, a description of what type of person gets this disease. The answer is, of course, number 4, a description of what type of person gets this disease.